Okay, we'll go ahead and get started here. Thank everybody for coming, and for those of you that don't know me, I'm Dick Wigle, one of the trauma surgeons. We're going to talk about heat injuries today. Some of you may remember this headline. I apologize, it is from Fox, so a little over exuberant. But this showed up about 2 years ago, and you think about this and you go, this football player falls dead on the field, basically from heat exhaustion. And we have seen that in reality, that's probably more common than not. They just happen to pick out this one player. As a matter of fact, if you look at environmental injuries and environmental deaths, heat stroke is by far the leader in causing deaths in America than all these other things combined. Between 1979 and 2002, heat stroke caused more deaths than hurricanes. Oh, sorry, I already did that. 2003, and actually I was in Europe at this time. 2003, a heat wave struck Europe. Europe was unprepared for this. I mean, you don't have air conditioning in most places in Europe because you don't need it. And there were 22,000 to 45,000, depending on who you read, deaths due to this. Interestingly, many occurred days, weeks, or years later, and we'll talk about why that is in a little bit. But deaths from heat stroke have actually occurred up to 30 years after the incident itself. Now, in 2019, there was another heat wave in Europe, actually in July this year. They were prepared for it, and casualties were very low, except in the Netherlands for some reason, where they had 400 deaths. Well, it all goes back to the fact that the human body doesn't tolerate heat very well. It requires a very narrow range of internal temperature, 35 to 41 degrees centigrade. Much above this, much below this, you've got a problem. The internal temperature is a balance between the heat produced, heat absorbed from the environment, and heat lost. And this just makes sense. Normally, heat produced is 60 to 70 kilograms or kilocalories per hour. But if you're exercising, you can get a burn up or produce up to 900 kilocalories per hour, and this has to be gotten rid of. Other things that contribute to this, without necessarily exercising, hormones and drugs. It can be mediated by the central nervous system and certain neurologic issues. And solar radiation can add another 150 per hour. Now, how do you get rid of heat? It's either convection, conduction, radiation, or evaporation. Convection and evaporation is how we normally do this. And everybody knows this. You're sweating. Evaporation of 1.7 mils will consume 1 kilocalorie of heat. Maximum about 600 kilocalories per day. However, this is in a dry climate. Doesn't work very well above 75% humidity, and God knows we wouldn't see that, would we? Radiation can be an effective way to dispense heat, but mostly it's from the head. And so if your head is covered up, you lose that mechanism. We also hinder our ability to get rid of heat in other ways. Dehydration, obviously, this decreases the circulating volume in the body and makes it harder both for convection and for evaporation to work. Circulatory failure. You have a cardiac issue and your circulation is decreased, your cardiac output is decreased, you're going to have an issue. Old people and young people have issues with this. Young people because of the increased surface area of the body and some lability in their central thermostat. And old people, a lot of this is just drugs and lability in the thermostat. Obesity, God knows that's not a problem here. Clothing. And drugs. And a lot of the drugs we take, particularly the elderly take, will diminish your ability to lose heat. Dehydration. Normally we turn over about 22.5 kilograms of water in a cool climate. In a hot environment, for some reason, voluntary water intake does not keep up with the loss. And you have something called voluntary dehydration. And the reason for this is unknown. It's probably some glitch in some central monitoring system. There's an obligate sodium loss with all water loss. And the bowel can act as a source of water. And electrolytes, it can also act as a source of loss. Gastroenteritis severely multiplies the risk of heat injury because, again, you're dehydrated and you've lost circulating volume also due to loss of sodium. 10 things are classified as heat injuries. We're not going to talk about all 10 because they get kind of obscure. We consider 3 as significant: heat cramps, heat exhaustion, and heat stroke. Heat cramps. This is the kind of thing that they try to train people up for. And acclimated individuals, you're much less likely to develop heat issues. And this is probably due to peripheral fluid and electrolyte imbalance. Heat exhaustion may occur over several days. There's 2 types of heat exhaustion: sodium depleted and water depleted. Sodium depletion presents with vascular collapse. Obviously, you have decreased circulating volume. And patients with water depletion present with thirst and oliguria. Again, that makes sense. Your body sensors are telling you that you are short. Most of the time, you have a combination of the 2. You've got both sodium depletion and water depletion. And again, that makes sense when you consider how you lose sodium and how you lose water. If you're water depleted, again, loss of the ability to sweat, you're more likely to progress to heat stroke. And that's what we're going to talk about pretty much from now for the next few minutes. It's classically described as having increased core temperature greater than 40 degrees centigrade with central nervous system dysfunction and anhidrosis. You lose the ability to sweat. It's been redefined in 2002 as a form of hyperthermia associated with a SIRS response. And this is really what's behind most of the issues. The SIRS response is where you get these people that have issues 30 years down the line, just like you do in sepsis. Long-term disability is, with increased mortality, is an issue even if you survive heat stroke. Again, this doesn't apply for heat exhaustion or heat cramps. But heat stroke, once you've reached that point with the massive SIRS response, you can expect to have at least some long-term disability if you survive. Military has looked at this. Obviously, this is a major issue for the military, not only because of where they train, but where they go to fight. In a military review, about 40% had increased mortality, cardiovascular issues, renal and hepatic failure within 30 years. Again, we're back to that 30 years down the line. We mentioned this before, the 2003 heat wave, 22,000 to 45,000 deaths. One hospital in France published their experience. They had 83 patients total. 28-day mortality was 58%. I mean, that's significant, 58% mortality. And 2-year mortality was 70%. I mean, that's even more impressive. Basically, all heat illnesses can be considered an accelerated process of normal defense mechanisms. Multi-organ failure with SIRS response and heat stroke. And again, like I said before, the SIRS response is really the big issue. I don't think I need to really go into what the SIRS response is. You've all seen this list before. but we should mention that DIC is part of heat stroke. When you have temperature in the range of 43 to 45 degrees centigrade, platelets are activated and may be irreversibly activated even after normal cooling is established. Fibrin is deposited in small vessels and you develop a consumptive coagulopathy, which usually turns out to be fatal. So what do you do about this? Heat cramps? Well, it just makes sense. It's what we've been doing for years. You take it easy, stop doing what you're doing, cool off with oral fluids or IV fluids with sodium. This is the old go get a salt pill. Most of you are probably too young to remember that. You remember it. Military training. Mandatory salt pill every hour. Thank you. Heat exhaustion. Exactly the same. Cool them off. Stop doing what you're doing. Give oral fluids or IV fluids. And again, the type of fluid you're giving depends on whether the patient has water depletion or salt depletion. As we said, usually this is a combination of the two. Evaporative cooling is the easiest way, and this again has been studied by the military. Generally, the safest thing that can be done in most circumstances. And what that involves is basically either totally exposing the patient. This is what the military does. Totally exposing the patient, let fans blow over them, put a cool soaked sheet over them, and most of the time this isn't a big issue. Heat stroke, however, as we already said, this is a SIRS-involved process. What do you do for it? Well, you start them on oxygen, start fluid administration. These all make sense. But the critical thing in heat stroke, and the thing that was not done with the fellow in the first slide, was they didn't monitor the core temperature and drop the core temperature rapidly. The ideal is the core temperature should be placed or put back to normal within 1 hour. So aggressive cooling is the approach for heat stroke. Ice bath. If you've got an ice bath, that's the way to go. And you can actually take the patient too far down with an ice bath. The Army has gotten away from this. And again, they have a large experience. Rather than immersion, the Army strips the patient, covers with bed linen, soaked in ice water, and replenished with ice water rather than just looking for evaporative cooling. This, of course, is useful because it's something that can be kept anywhere. And the equipment to do this is kept at the first aid tents so that the patient can be cooled immediately at the scene and transported while cooling is going on. As I said, the goal is to try to get core temperature back to 101 Fahrenheit within the first 60 minutes. And this probably diminishes the SIRS response. Other things that could be done: ice packing at the axilla and groin, gastric lavage with cold fluids, peritoneal lavage. I've seen people or heard of people that actually put chest tubes in and lavage the peritoneal or the pleural space. But all of these are ways to try to get the temperature down. There's some recent studies showing that the devices they use for hypothermia in cardiac arrest is very effective if you have access to that. Some things have been proven to be of no value. That's recombinant human activated protein C. This was going to be the big deal in sepsis a few years ago. Anti-endotoxin antibodies, ibuprofen, anti-TNF, and all of these things. All of these things have been suggested. None of them have ever shown any value. So basically that's it. Sorry it's so short. Are there any questions on any of this? Well, I mean, if you're out in the middle of combat, you know, you're not going to have ice. This is what the difference here was, you know, rather than transporting the patient and putting him in an ice bath at the medical care facility, you start the cooling at the site and transport them while they're still being cooled. Okay.
Where's the picture?
Where's that from? Kuwait. Just driving down the road. Okay, like I said, I'm sorry it's so short, or maybe not.